Good morning and welcome to this Mental Health Summit. It's a privilege to participate in this event today, and I hope I'll be able to explain why I, as Head of Department of Biomedicine, am talking in a seminar such as this. I'm going to start with speaking about its relevance particularly in aviation, but by extension in other areas and populations also, and then some resources that are now available through our department, including Neurofeedback, Transcranial Direct Current Stimulation, Hyperbaric Oxygen Therapy, and brain reward. Now, to start off with relevance, I'm not sure how many of you recognize this picture and what it represents, but on the 24th of March, 10 years ago, Germanwings Flight 9525, carrying 150 people, of which 144 were passengers, took off from Barcelona to Düsseldorf. For the most part, the flight was no different from any other flight, other than the fact that the co-pilot, Andreas Lubitz, had a psychiatric history. He had been hospitalized for depression and suicidal tendencies in 2008. After that, he worked as a flight attendant in America, thereby paying for his training as a commercial pilot, joining Germanwings in 2013. The sad part is that during this flight, he locked the cabin of the aircraft while the captain left for a bathroom break, and upon returning was unable to enter. Andreas had, prior to this, set the piloting of the aircraft to make a collision into the Alps, and at a speed of 700 kilometers per hour, with the captain beating on the door and the passengers screaming and crying out, this pilot single-handedly destroyed 150 lives. And the question is, why and what could have been done to prevent this? And what should we learn from this? This clearly was not the first accident involving a captain with mental health issues. Apart from Germanwings, there was a flight by Egyptian Air in 1999 in which 217 people died when the first officer, depressed, descended into the Atlantic. Silk Air, 1997, 104 passengers died, again as a result of a fatal dive. And in 1982, even earlier, Japanese Airlines 350, killing 24 passengers when the captain, who was mentally ill, reversed thrusters deliberately on takeoff, thereby precipitating a crash. We can say that since 2015, things have never been the same, and mental health has come to the forefront in aviation like never before. We have realized that there are tremendous challenges to mental health in aviation. Almost anything that you would recommend to someone to preserve mental health is disturbed during aviation duties. There's fatigue, isolation, stress, frustration, a need to attend to passenger safety and emergencies, to deal with variables like poor weather, high stress security threats, dynamics within the cockpit with crew that one is unfamiliar with, emotional strain related to personal issues as well as work, tremendous cognitive demands when flight plans change, and during peak seasons of travel, increased stress. Following the 2015 fatal accident of Germanwings, Harvard performed a study based on more than 1,000 pilots in which they discovered that 12.6 showed signs of clinical depression. 4.1 had suicidal thoughts, and in a recent study in which there had been near-miss incidents, it was found that 6.5% of the pilots tested had alcohol in their system, and 11.4% tested positive for illicit drugs. Sadly, slightly more than half of those with diagnosed mental health conditions sought help and were willing to report it to their employers. Since peer support programs have become mandated by the International Civil Aviation Authority, but we have a dilemma in the Middle East, quite a unique one. The cultural and religious environment discourages the use of anything that confuses or stuns the senses, including alcohol, but that is not to say that alcohol and drugs are not a relevant problem. The sad reality is that there's a denial of the problem, there is an ongoing stigmatization. Once this is discovered, either accidentally or if reported, it may lead to immediate suspension and or even summary dismissal. There is an extreme lack of support services for recovery and rehabilitation, as we found with a pilot that we recently helped overcome an alcohol abuse problem. An additional dilemma is that the medication that would typically be prescribed for mood or other psychiatric disorders are not compatible with duties of pilots, commercial divers, and those handling heavy equipment, machinery, or even public transport, for reasons that are obvious but include impaired judgment, reaction times, drowsiness and sedation, disorientation, mood instability, even visual disturbances, dizziness, risk of dependency, withdrawal, various drug and environmental interactions, the masking of underlying symptoms, and policies by the various regulatory authorities that these would be a disqualification. I'd like to end this section on the relevance by quoting Daniel Amen, who's known for his neuropsychiatric approach in terms of looking at the structure and function of the brain. And in his work, a New York bestseller, The End of Mental Illness, he very profoundly states, reframing the discussion from mental health to brain health changes everything. People begin to see their problems as medical and not moral. It decreases shame and guilt and increases forgiveness and compassion from their families, something that is essential for recovery. In addition, mental or brain health and its support in aviation and diving and occupational medicine is not a luxury. It is a regulatory, ethical, and performance imperative. As far as resources are concerned, I'd like to first start by showing you our department so that you get a sense of why and what we do and where we do it. So as you come on the first floor, and any of you that might be interested to see our configurations are welcome to speak to me after this talk and maybe in one of the breaks, and I'd be happy to show you. So we have a nursing aspect, which relates mostly to advanced wound care. And then in the latter parts of the department, we have the change rooms for patients undergoing hyperbaric treatment. And here is the neurofeedback room. And this simulated patient, a volunteer, is undergoing neurofeedback while Millicent Cronje is monitoring and adjusting so-called thresholds, which I'll mention later. That's my office. And in the main treatment area are two chambers, Baloo and Bagheera. Usually Sister Lucy Cronje is sitting in that chair and or next to the chamber. This is where we do transcutaneous oximetry assessments. And in the room directly adjacent to this treatment area is our multi-purpose aviation medical room, in which I do vestibular and balance rehabilitation, diving and aviation medicals. And in the brown chair that you can see just to the left of this last image, we do the Transcranial Direct Current Stimulation. So we have 7 different lines of service that we provide, but in terms of neuromodulation, I would like to address these 4. Neurofeedback, Transcranial Direct Current Stimulation, Hyperbaric Oxygen, and KB220, otherwise sold as Brain Reward. Now, I'm going to be referring to levels of evidence that are in support of the modalities that I've mentioned, And so I just want to briefly touch on the highest levels of evidence according to the Oxford Clinical Evidence-Based Medicine levels of evidence. And level 1 means that there are a variety of meta-analyses of randomized controlled trials that are similar enough that the results can be joined or collated and made applicable to the population of concern. 1B means that there is a high-quality individual randomized controlled, usually placebo-controlled trial with a narrow confidence interval that essentially means that we are 95% confident that the intervention will have a significant positive impact. Level 2 includes a systematic review of cohort studies where a group is studied for an effect, or 2B, where there's an individual cohort study or perhaps a randomized controlled trial that doesn't quite meet the A grade, but is nevertheless very significant. So 1A, 1B, 2A, and 2B. So let me start with neurofeedback. Now, I don't know how many of you are familiar with neurofeedback, but neurofeedback essentially is one of the forms of biofeedback in which we mirror the physiological measurement to an individual and thereby encouraging to get mastery over that particular dimension. And in this case, in terms of brain and mental function, we use a non-invasive EEG tracing, so an electrophysiological signal from the scalp, and mirror that back to the patient through a system that I'll explain in a moment, that then allows them essentially to see what they're thinking. And through operant conditioning, which means that we reward positively or reward negatively, there's no punishment, but negative or positive rewards in terms of how what they are watching functions, they then learn to attain the desired brain state. Now, it's a very important thing to say we're not putting anything into the brain. We're merely measuring what is in the brain and giving the person and the brain a somewhat subconscious opportunity to recover and to restore. And it's shown to improve cognitive performance and emotional stability. So just to give you a sense of the setup, you can see the client over here. The client is attached based on whatever the reason for getting neurofeedback is on a series of sensors at specific sites on the scalp. These are fed to an amplifier that delivers them to a computer with specific training or neurofeedback software. This then, on the basis of what the clinician has realized or has been reported to in terms of symptoms and the feedback from the patient, the choice of sensor placement in terms of position, and then during the neurofeedback session, an ongoing adjustment both in the frequency choices and also in the rewards, positive or negative, that the person is able to attain. This will become more real when I show you actual live footage of what happens. The signal is then fed to a television, which then either brightens or darkens as the person watches a movie of their choice or they play a video game. And simply the darkening and brightening or starting and stopping of this interface, the individual simply needs to want to watch the movie. And as long as they do, the feedback that they get will allow the brain to compare its current mental state with the ideal mental state where the movie plays, and over 15 to 25 sessions, this becomes a long-lasting change. Now, I mentioned evidence, and the evidence is the strongest in using neurofeedback for ADHD, but also insomnia, anxiety, depression, PTSD, and to a lesser extent, substance disorders and autism. But it improves attention and sleep, reduces symptoms, improves relaxation and mood regulation, less impulsiveness and reactivity, better emotional control, and to some extent reduced cravings and attention and social functioning in autism. Again, to make this real, I'm going to share with you a 41-year-old person's case study who was a European psychotherapist who came to us with a variety of mental health concerns after she herself went through a series of psychological and psychiatric interventions, including cognitive behavioral therapy and hypnotherapy. We asked her to self-report, and fortunately, being a professional therapist, she had the ability to articulate what she felt. And she said that before starting the sessions, she had emotional dysregulation, disorientation and blurred or foggy thinking, heightened sensitivity to sound and light, social withdrawal, and mental fatigue and exhaustion after especially undergoing a hypnotherapy session. After 30 neurofeedback sessions that were spread for a variety of reasons over 4 months, she reported the following: a marked reduction in anxiety, a restoration of emotional composure and resilience, enhanced mental clarity, creativity, and depth of thinking, improved mood regulation, ease in expressing emotions, increased focus, the ability to experience emotions deeply but without fear or shutting down, and her speech also became more deliberate and more specific and less agitated and sometimes garbled. Now, it's all very well to report this and to say that this proves that neurofeedback has an effect, but I'd actually like to show you the changes electrophysiologically, and to do that, I'm not expecting you to be able to read an EEG, but surprisingly, you'll probably be able to get the gist of it. What you're seeing here is a so-called 1020 assembly of electrodes on the scalp, going from the nasion, or the bridge of the nose, to the inion, which is the bump at the back of the skull, and is positioned in a particular standardized configuration. F3 is in red because I'll be referring to this site a little bit later and its significance. Now, the EEG montage that I'm going to be showing you follows these sensors in the direction that I've outlined. So it takes the frontal ones, then the prefrontal ones, then eventually the sensory motor strip, parietal, and finally the occipital. So this is the EEG with a superimposed picture showing you essentially the electrode placements. And what you probably can see is quite a lot of waves. These are largely alpha waves that are distributed throughout the brain. This was on the 13th of March 24, and this was on the 13th of July 24. I think even for a lay observer's view, you can see this is more agitated than that. But it's all very well, once again, to say this. How can we quantify it? And that is where quantified, or QEEG, comes in. What I'm going to show you next is a breakdown of the different frequencies, essentially from a sleep state, a twilight state, awake and relaxed state, thinking, and ultimately anxiety. And again, I'm going to show you where these sit in relation to the various senses. So here in this case, the sites that you'll see essentially are a direct two-dimensional representation of what you see on the illustration. And here you see the breakdown of the low frequency all the way up to the high frequencies. And this is the prior assessment, and this is the subsequent one. And perhaps it's a little subtle, but what you should see is that there is a normalization of frequencies throughout the brain. If that is too subtle, let me show you this table, and particularly the change in alpha rhythm. What you will notice before is that there are a wide range of frequencies in certain areas of the brain, which after the neurofeedback sessions became far more homogeneous. In getting an objective interpretation of this, the following was concluded: that the alpha frequency change from 10.5 to 9.7 was a representation of a transition from being hyper-aroused to a relaxed alertness with reduced stress, anxiety, and cognitive overreaction. And there's the reference that actually shows this can be correlated. The reduction in alpha amplitude means increased cortical engagement or alertness and potentially improved attentional control. The reduction in delta or theta, in other words, the sleep or the dream state in part of the brain, represents improved vigilance, reduced fatigue, or enhanced cortical activation, particularly in the frontal circuits, which is where we have all our executive function and emotional control, including the ability to communicate. And then the frontal beta wave reduction represents a reduced hypervigilance or anxiety, which is often seen in anxious populations. As you might recall, these are the series of changes that were reported spontaneously by the individual. So the change was not only qualitative in terms of their subjective assessment, but it was objectively visible on this electrophysiological footprint. Now, you can get a lot of information from medical journals published on how neurofeedback has an effect in various states, including aviation, and most recently also in NASA-related work, both in relation to the moon and the Martian habitat. But these can sometimes be quite difficult to penetrate if you don't first have a background. I would therefore recommend the following 3 reads. Some of you may be familiar with Bessel van der Kolk's Tour de Force and New York bestseller called The Body Keeps the Score, and chapter 19 is one of the single best summaries on the essence and purpose of doing neurofeedback. So I strongly encourage you at least to get that chapter. A somewhat dated book, but an excellent overview of the development and background of neurofeedback is in Jim Robbins's A Symphony in the Brain. And then lastly, Hanno Kirk's Restoring the Brain, 2nd edition, which covers the whole field of applications of neurofeedback. Next, Transcranial Direct Current Stimulation. Now, what on earth is this? It's essentially an electrical or electrotherapy which targets mostly that F3 site that I showed you, also known as the dorsolateral prefrontal cortex. Dorsolateral prefrontal cortex, which is involved in mood, cognition, and emotional regulation. I'll give you the specifics in a moment. The mechanisms of action, by applying a 2 milliamps, so we're not comparing this in any way to electroconvulsive therapy. These are very, very small currents, applied for only 20 to 30 minutes with a fully conscious patient. What they do over the area where the anode sits, they increase cortical excitability and therefore cortical output by maintaining an elevated subcortical activation. And after 10 sessions, the plasticity leads to these results being lasting. Why is this significant? Because that dorsolateral prefrontal cortex plays a role in executive function, including planning, decision-making, working memory, and cognitive flexibility. In other words, the ability to think and adapt in a new situation. Attention and focus can be sustained or appropriately shifted. Emotional regulation is better modulated and negative emotions are suppressed. There's better goal-directed behavior, which means there's an active organization or a movement towards things rather than a withdrawal. And there's better cognitive control, which means less impulsivity and the ability to manage conflicting information without just being black and white and being unable to separate between those. So F3, the dorsolateral prefrontal cortex on the left hemisphere of the brain, is linked to approach behaviors and positive affect, or positive mood, and is a common target both in neurofeedback, transcranial direct current stimulation, magnetic stimulation, in particularly depression, ADHD, and in those contexts in which cognitive function needs to be improved. And this has already been shown to be effective, for instance, in improving simulator performance. In terms of the evidence, as I mentioned, it has been used for depression, ADHD, chronic pain and stroke rehabilitation, cognitive boosting, addiction, fatigue, and anxiety, in which largely F3 is targeted, and you can see the impact. Less depression, better attention, less impulsivity, less pain, better motor recovery, better working memory, less craving, less fatigue, and less anxiety. And you can see the levels of evidence there ranging from 1B to, at the last one, 2B, up to 3B. And the reason for the difference is because there are sometimes differences in equipment, differences in montages, and also differences in current density, meaning that the sponge that is put on the head is sometimes larger, and therefore the ultimate flow of current through the scalp may be diluted. And that's a very important thing for those of you that are interested to get into this field. Next, hyperbaric oxygen therapy. Now, hyperbaric oxygen therapy is simply breathing oxygen in an environment, that being a pressurized chamber, at a pressure of either 1.5 all the way up to 3 times the atmospheric pressure here at sea level. It then is able to increase the oxygen gradient, in other words, the drive of oxygen into tissue, by a factor of 10 to 15, and it can meet the whole brain's metabolic demand. And I'll explain a little bit later that the brain, under normal conditions, has to choose which functions get preferential treatment in terms of delivery of oxygen and nutrients. In the hyperbaric chamber, the brain does not need to select. There is ample oxygen available everywhere. Now, our brain only makes up 2% of our body mass, but it uses 15% of the cardiac output or blood circulation and 20% of oxygen that is taken up in the lungs. And therefore, as you're sitting here, there is relative hypoxia in your brain, or hypoperfusion, because your auditory cortex is activated as you're listening to me at the expense of other areas of the cortex, which is why multitasking is sometimes hard for individuals because of this, essentially the draw of both nerve function and circulation into certain areas. As a result, circulation may be removed or decreased to other areas of the brain, which translates to a reduction in the function of the so-called default network, which is the state your brain is in when you're alone with your thoughts, which is usually where people with mental illness find it the toughest. And then, of course, an inevitable competition for resources. Now, in addition to giving all the oxygen that the brain needs, whatever the nature or direction for recovery would be, it has been shown conclusively that hyperbaric oxygen optimizes oxygen metabolism by improving mitochondrial function, those little powerhouses in the cell that process oxygen to form water, and in the process ATP, or cell energy. It releases stem cells, which is, as you're sitting here, continually replacing parts of your body organs. It reduces inflammation, which is common to most of these neurological and neuropsychiatric conditions, improves synapse formation, neurogenesis, especially in the hippocampus, where it's been shown that there are resident stem cells that are able to develop into neurons. It improves the microcirculation and thereby, in total, enhances neuroplasticity. So in clinical settings, and particularly in mental health, HBO has been shown to be effective in long COVID by reducing the neuroinflammation and restoring perfusion and neuroplasticity, and also heart function. In mild traumatic brain injury, there has been significant cognitive recovery, cerebral perfusion, and reduction in neuroinflammation, together with improvements of PTSD and other comorbid mental state markers. And you can see there that there's level 1B evidence. So there's a very, very high quality randomized sham-controlled trial that was done by Lynn Weaver, and it was published this year. You can even see that the COVID literature is recent, clearly, because COVID was relatively recent. And those two studies are also randomized, placebo-controlled studies involving cognitive function and cardiac function, both of which were able to be restored to their pre-morbid, pre-COVID state. PTSD, significant improvement in the CAPS-5 score and in connectivity throughout the brain. In fibromyalgia, reduction in pain and fatigue, improved quality of life and sleep, and cognitive decline in normal individuals. So in other words, non-Alzheimer's, although it may have an effect in early Alzheimer's, but essentially normal aging can be reversed to some extent. And again, the evidence is quite strong. Now, at this stage, you might reason, as we did, that there would be a lot of sense in combining some of these therapies. The first of which would be hyperbaric oxygen and neurofeedback, if we can allow the brain to be directed in the renewal or recovery state that it should achieve, and at the same time provide the necessary resources and oxygen for it to do so, it would stand to reason that the outcome should be better. And these are my co-authors of a paper that was presented at a recent Saudi conference, the inaugural Hyperbaric conference, and in August last year was the event in which it was put together for the first time in the world. And just to give you an idea, this is literally our first patient who came with long COVID as well as mild traumatic brain injury since childhood. And here you can see my daughter Millicent, who is our neurofeedback technologist, applying the sensors in the identified areas on the scalp. And after the preparation, the patient is pushed into the monoplace hyperbaric chamber. And this is the tracing. And the top graph is the raw EEG. And these are the subsets of frequencies that are either positively rewarded or negatively rewarded based on whatever the symptoms and objective is in terms of this patient. So here, during the oxygen breathing, the patient simply watches a television and we adjust the image's response to the brain frequency signals, thereby allowing them to undergo the neurofeedback. So the essence essentially is the amplifier outside the chamber and the electrodes inside the chamber with this pass-through, allowing us to do the neurofeedback simultaneously. And because we're only tracing physiological signals, it's entirely safe in a 100% oxygen-filled chamber. So when might we consider combining hyperbaric oxygen therapy and neurofeedback? Well, that would be in long COVID, traumatic brain injury and possibly certain forms of stroke, PTSD, and refractory, that is untreatable or highly resistant fibromyalgia, and the same for resistant PTSD. Lastly, I'd like to tell you about a so-called neuroadaptogen called KB220. Before I go further, I'd like to make this disclaimer that KB220 is a patented formulation pioneered by Professor Kenneth Blum, who started studying alcoholism in America and the difference between the Europeans and the North American Indians and the vulnerability of the North American Indians, and him finding that there was a genetic variant in the so-called dopamine 2 receptor that made them vulnerable to dopamine deregulation, so-called reward deficiency syndrome, and addiction. I have no commercial interest, financial stake, or proprietary rights. In fact, it's still quite a hassle to try and get it anywhere, let alone Bahrain. And my research has purely been motivated by an interest in advancing scientific understanding and establishing better, even best clinical practices. So the research has been unfunded and merely been because I believe in what it can do, as you'll see shortly. These are 4 of the papers that I've been involved with, and the last I was the lead author, and I will show you exactly what we did. So KB220 is, as I said, a neuroadaptogen or neuronutrient, which primarily improves or supports dopamine balance and enhances the brain reward system and function by reducing craving and addictive behaviors. And you can see the constituent parts. They're available readily through the US patent, or you can see them in our paper as well. And this is what the bottle looks like. It's unscheduled, so you're actually able to get it off the shelf. And we're trying to find an easier way to get it available to those that need it. In simple terms, what KB220 does is it optimizes the neurotransmitter cascade from serotonin to encephalin, which is essentially our own form of morphine, GABA regulation, and ultimately dopamine release and sensitivity to its release. Dopamine is the reward neurotransmitter in terms of its cognitive function, and therefore maintaining that in people who have suffered from addiction or even depression is a significant improvement. Linked to this product has been the development of the genetic addiction risk score. In this, the so-called reward deficiency syndrome or addictive behaviors are identified, or the predisposition is identified based on various polymorphisms or genetic variability in the dopamine, serotonin, GABA, and opioid pathways by looking at specific SNPs or single nucleotide polymorphism. it is then added to an addiction score, and this translates to vulnerability. The clinical utility would lie in both early intervention with neuronutrient therapies and avoiding relapse risk. And together with Dr. Fiba and Dr. Vivek, we actually recently were able to assist a pilot withdrawing from alcohol abuse and 3 months later being reinstated back into his job, fully functional and completely alcohol-free. Now, the mechanism involves, as I said, dopamine, serotonin, and GABA, but most rehabilitation medications are related to the sedatives, like alcohol, like opium, and there are few drug substitutes that are used for stimulants, like cocaine, etc. KB220, being a neuroadaptogen, actually allows the brain to optimize itself in either direction, whether it is suppressed or whether it is hyperexcitable, as I'll show you shortly. Now, in terms of the scheme of things, KB220, by and large, has 2B level evidence in addiction recovery, ADHD, PTSD, memory and cognition, depression, reward deficiency syndrome, and resting state network recovery, as well as relapse prevention. Now, perhaps this doesn't look impressive, but let me put to you the supplements at this stage for which there is the highest volume of research. Omega-3, of course, tops it with 1A level evidence that it reduces inflammation and is neuroprotective. But other supplements like magnesium, which we know reduces migraines by 50%, N-acetylcysteine is an antioxidant, B vitamins that are clearly useful and are notable, like in Korsakoff psychosis, etc., vitamin D, zinc, L-theanine, and probiotics. And KB220 comes in ninth. If you compare all the supplements out there, this is quite impressive. But let's not just give it to you subjectively. I'd like to share with you a case study that we actually did a 1 hour before and after EEG. In other words, this individual who had a variety of psychiatric conditions, including depression, post-traumatic stress, autism spectrum, sensory integration disorders, and a variety of behavioral abnormalities, we were able, literally, 1 hour after getting his initial EEG, repeating that and seeing the effects. Now again, I'm not expecting you to interpret the EEG, but you'll probably be able to see that there are largish waves that essentially make up a fifth of a second. So we're talking about delta and theta range, and that these predominate in the frontal lobes. And that basically means this individual's frontal lobes are offline. They're not thinking straight, they're not able to concentrate or focus, they're distractible and have poor impulse control. This is literally 1 hour afterwards, and you can immediately see the improved electrical activity in the frontal lobes. And you can imagine that this person had been sitting in the chair undergoing the initial EEG, waiting for 1 hour in the chair, without moving, without anything changed, getting another EEG, that if anything, they would be more sleepy towards the second one, especially in this eyes closed recording. The opposite was the case, and you can see the recovery of faster frequencies in the frontal lobes. Let me show it to you on this graph again, and just point your attention to the prevalence of these low frequencies. In other words, this part of the brain is asleep, and 1 hour afterwards, this is the change. Let me show it again. From there to there, in 1 hour after taking 4 KB220 capsules. Now, what does this mean in practice? Well, it means that the person was able to wake up, and secondly, that their alpha rhythm became more homogeneous. In other words, the hum of the brain was consistent throughout. We then, in order to try and get an impartial interpreter, provided these findings to AI Neurology, which is an excellent ChatGPT-4 driven neurology service, which is really something to look for if you haven't already considered it. And what it said is that the observed changes are consistent with the published literature on dopaminergic activation and neurochemical modulation of KB220, with increased posterior alpha power associated with improved attentional regulation, relaxation, and cognitive efficiency, reduction in frontal delta, meaning enhanced executive control and reduced cortical inefficiency, and stability in gamma and beta, meaning there's no overstimulation, which, as I mentioned earlier, is important for people who either are coming off sedative medication or addictions or overstimulation of the brain. The EEG data 1 hour after the administration demonstrates enhanced alpha power, reduced delta in the frontal regions, and increased cortical efficiency and dopaminergic tone. The findings suggest a neurophysiologically favorable response to KB220 with no signs of cortical overstimulation. So these are the findings in a patient 1 hour before and after, so as advertised, and there's nothing that compares to this. So in conclusion, I leave you with the following. Baromedicine offers some unique modalities for support, particularly neuromodulation. We base what we do on objective electrophysiological findings, but compare to clinical findings, which then direct the choice and determine the combination of interventions. We follow a function-based outcome and a non-pharmaceutical brain health approach, which is compatible with aviation safety and aligns with many patients' preferences nowadays. Patients are afforded hope, they are empowered, they have a better understanding of what's going on within their brain, and they can actively partner in their own recovery. So we wish to advocate for integrated practice units where mental health practitioners and our department can collaborate, better support service for people in Bahrain and elsewhere with substance abuse conditions, better occupational medical mental health support, obviously more research and clearly more education, and then ultimately an integrated approach to neuromodulation for optimal recovery and resilience, with a call for implementation. So for those of you that would like to find us or make bookings with us, you can simply Google KHAMH and aviation and you'll find our website. And if you go to that, you simply click on our services or make a booking. You find Neurofeedback, and here you find the complimentary consultation we give, so people can literally just come and talk with no financial commitment, and we can simply suggest the path that we might follow. If they ultimately undergo a quantitative EEG, we can then determine whether neurofeedback is appropriate and whether the short or longer protocol would be recommended, and or transcranial direct current stimulation. So with that, I close and invite you to provide whatever questions you might have. Thank you.